Ladies and gentlemen, I'll begin a short talk on the karyotypes and congenital heart diseases in children with Down syndrome, as was noted in the place where I come from, that is from South India. Now, just an overview of that. Chromosome 21, as we all know, well, the karyotyping about chromosome 21, the congenital heart disease, and then what is the incidence of congenital heart disease and the karyotyping in published literature, results of a study and how it is different, the conclusions and the recommendations. Chromosome 21, we are all aware that trisomy 21 is because of the triplication of chromosome 21. It is the smallest human autosome, and it represents 1 to 1.5% of the human genome. It has 48 million nucleotides and carries more than 400 genes. The most acceptable theory for the pathogenesis of trisomy 21 is a gene dosage hypothesis, which states that all changes in Down syndrome are due to the presence of an extra copy of chromosome 21 as a result of either non-disjunction or translocation or mosaicism. That is, there is an extra copy of the 400 genes that are seen in chromosome 21, and they are responsible for all the features that you see. The cytogenic analysis, otherwise known as karyotyping, is indicated in every person suspected with Down syndrome, not only for confirmation, but also to assess the risk of recurrence. Now, this is very important because we got to tell the parents about the risk of recurrence. And for that, you should know what is the type of karyotype. The risk depends on the type of trisomy of chromosome 21. If a translocation is identified, parental karyotyping should be done to know whether they are translocation carriers. Here again, as I mentioned earlier, there are 3 types, but if there are translocations, it could either be de novo or it could be from one of the parents. So the parents also have to be karyotyped. The carrier status and the sex of the parent that has a carrier status determines the subsequent risk of having another child with Down syndrome. In the world literature, non-disjunction is reported as the most common cytogenic pattern. 95% are because of non-disjunction, otherwise known as free trisomy, followed by translocation 4% and mosaicism 1%. Now, free trisomy is associated with advanced maternal age. It is due to differential choice and accumulation of trisomy 21 oocytes in the ovarian reserve of older women. So as the age advances, the accumulation of trisomy 21 oocytes increase. And that is probably the reason why we get non-disjunction in older parents. In our study in Kerala, South India, the place where I come from, 800 children with Down syndrome were analyzed. It's a retrospective study of children who was seen in the last 20 years, of which cytogenic analysis was done in 582. That is 72%, because in the earlier years, we couldn't get cytogenic analysis of all those who came to us. Non-disjunction accounted for 87.5%. This is as against 95% in world literature. Translocation 9.4% as against 4%, which is almost 2 to 2.5 times what is seen. And mosaicism 3.04% as against 1% in world literature. We had a higher incidence of translocation. The most frequent translocation noted in our study was T1421, which was 5.1%, followed by T2121, 3.6%, and T1521 and 2122, 0.17% each. Translocation T1421 is more than T2121 in many of the studies, but its incidence was higher in our study when compared to others. In general, our translocation was high, and maybe that's the reason why the incidence of T1421 was more than what is seen in other studies. Now, this is just a graphic representation, figure of a table of what I have just now mentioned. Non-disjunction 87.45%, all translocation 9.47%, with these, and other translocations are not being included here. And we also had some non-classical variety of cytogenical pattern. Our study was comparable with some other studies done from South India, but some Indian studies and other studies done outside India had values described as in literature. So we found that our study was similar to one or two publications done earlier from South India, but it was not similar to what was published from North India. Now coming to the maternal age and trisomy 21, less than 20 years of age, we had 12.3%, quite a large number. 21 to 25%, 27.1, 26 to 30%, 26.3. So we know that mothers less than 30 years constituted a large number, more than 60% were in Down syndrome was born to mothers less than 30 years. So maternal age at birth of all children with Down syndrome study ranged from 16 years to 50 years. 16 years was the youngest mother which we had. And majority of children with Down syndrome were born to mothers younger than 35 years. 81.87%. Now, why the 35 years is because we usually say at about 35 years, the chance is very high. And only 15.25% were born to mothers older than 35 years. Age was not known in 2.87%. Early marriage and early reproductive life are customary in India, as in some of the Oriental countries, as a result of which trisomy 21 associated with older maternal age may be less. This also may be responsible for the increase in the translocation Down syndrome in younger patients. As mentioned earlier, when mothers above 35 years, the trisomy oocytes are increasing. Now, because the mothers are mostly younger than 30 years, the chance of an increased trisomy 21 in the oocyte is less. And that may be the reason why, because the number is increased, we are getting more of translocation Down syndrome. Now, coming to congenital heart disease, cardiac lesions are the major cause of morbidity and mortality in Down syndrome. The reported prevalence of cardiac disease among children with Down syndrome is between 40 to 63% when compared to just 1% in children without Down syndrome. So a child who is not having Down syndrome, you check up 100 children, you have only 1% with cardiac disease, but somebody with Down syndrome, it's 40 to 63% from various studies. The most common congenital heart disease seen is atrioventricular septal defect in the world literature. Other heart defects commonly seen include ventricular septal defect, atrial septal defect, PDA, and TOF. But in our study, 610 cases, that is 76% of the 800 study, had underwent detailed echocardiographic testing. Cardiac defects were seen in 356, 58%, almost on the higher side of what is has been described. That is, more than half of them are cardiac disease. When considering the individual CHDs, AST was the most common cardiac disease in isolation, 30.3%. That means if you take AST alone, it was 30.3%, whereas if you consider AST with combination defects, it was 55.6%. It was similar to the data from Central America and Libya, but different from what we had in India and other places. Here again, ASD was not the commonest cardiac defect reported in world literature. The dominant lesions observed are variable according to the different geographical areas around the world. We don't know what the reason is, even though they are all children with Down syndrome. From the review of international literature, the most common cardiac defects are as follows. In Western European countries and the US, ECD, endocardial cushion defect, constitutes 43%, VSD 32%, secondary ASD only 10%, TOF 6%, and PDA 4%. But 30% of patients have multiple cardiac defects. In Hong Kong, it was VSD, and Latin America, like what we had, it was ASD. So this is a picture of a table of what I've just mentioned. ASD was pretty high, followed by VSD and PDA, and then the ECD. Even though the percentage of VSD and ASD, PDA were normal when taken individually, in combinations, they were different. So second most common isolated defect noted was VSD and PDA, 10.6% each. But when considering the lesions in the combinations, the incidence of PDA was 36.5%, and the VSD was only 27.2%. That is alone, both of them are almost same, but in combinations, PDA was higher. ECD was seen only in 6.1% as against the world literature, TOF 2.8%, and multiple defects at 33%. In world literature, again, multiple defects are seen in 30%. Dominant lesions vary in different parts of the country too. We analyzed different studies from India. In 2 studies done from Mumbai and Cochin, VSD was the commonest defect, whereas another study from Delhi had shown AVSD as the most prevalent CHD. In our study, it was ASD. Babies with Down syndrome can have multiple cardiac defects. Multiple defects are seen in 33% of cases as mentioned above, and the commonest were ASD and VSD, ASD and PDA, VSD and PDA, ASD, VSD and PDA, and ECD with PDA in the order. Now coming to the analysis of the cytogenic groups and the CHD, we analyzed the cytogenic pattern and the incidence of heart disease, and it was found that the higher incidence of congenital heart disease was seen in translocations, that is 65.9%, when compared to non-distinction, which is only 59.4%, and mosaicism, which have a lower incidence of 35.7%. So it's possible that translocation carries more risk of being born with congenital heart disease. This again is a table of the same one, non-distinction, we had this number, and 59.4%, whereas translocation was 65.9% with a lower result value in mosaicism. So in conclusion, the number of young mothers less than 30 was pretty high. It was 65.7, almost 2/3 of the mothers were less than 30 years, even though it was 85% for mothers less than 35 years. The incidence of translocation was high in our study, and it may be because of early marriage and younger maternal age. What I mean is early marriage does not produce an increase in translocation, but the number of non-distinction is comparatively less in early marriage and younger maternal age group. And probably that's the reason why we had a higher incidence of translocation. We noted a higher incidence of heart disease in Down syndrome, and that stresses the need for routine screening of all babies at least by 6 weeks of age to avoid irreversible complications. We normally do an echo at birth or at the first contact with the child. And if that is normal, we repeat it after say 6 weeks to 3 months. Or if that is normal, fine, it goes on. Otherwise, we have a periodic checkup. And then what we want is to pick up before the child has an irreversible complication. More of congenital heart disease in translocation DS were also noticed in a study, but it may not be statistically significant because the number of cases of translocation when compared to the number of cases of non-distinction were less. And so the higher incidence in translocation may not be statistically significant. Now coming to the recommendations, younger maternal age and higher incidence of translocation stresses the need of routine screening of all mothers to rule out cytogenic abnormalities. Universal first trimester screening to be offered to all pregnant females, irrespective of their age. It should not be restricted only to the high risk group. In developing countries, since it may not be practical, screening is done only for mothers more than 35 years, or mothers who have a history of abortion or bleeding, or in case of an assisted delivery, assisted conception. But because it is very high, and because we have a large number of patients who are less than 30 years, we should offer them to all mothers a karyotyping, a trimester screening should be offered, and if necessary, further workup. Karyotyping of all children with Down syndrome should be done, if not only to confirm the diagnosis, but also helps in risk prediction in future. Here again, because our translocation is very high, is absolutely essential. And that is the reason why we got to stress on karyotyping to find out if there's an increased risk of translocation, and then the need for screening in subsequent pregnancies. There should be routine cardiac screening of all newborn babies with Down syndrome, as a higher incidence of heart disease is seen in children with Down syndrome. Irrespective of whether there's a cardiac problem detected at birth, or irrespective of whether you're not able to hear any cardiac murmur, it should be done routinely, because that will catch up the cases which are not detected at birth, so that you can avoid problems later on. So early diagnosis of heart disease is crucial in predicting the outcome, and if undetected, can result in irreversible pulmonary hypertension, which can make it inoperable, because the parents may not come to you for it. They may come only when there's a severe problem, and at that time, irreversible pulmonary hypertension would have set in, and then it makes it inoperable. CHT is a major determinant of mortality and morbidity, and even neurodevelopmental outcome in children with Down syndrome. Cardiac care must go hand in hand with management of all other comorbidities. And these are the references what I have just in our study. And thank you very much for your patient hearing.